Hey there, everybody, and welcome to this presentation on the dissociative disorders in the DSM-5-TR. In this video, we're going to learn about the diagnostic criteria for dissociative identity disorder as well as other disorders in that category. We'll explore differential diagnosis, identify some common co-occurring issues, and discuss prevalence. Dissociative disorders are characterized by a disruption of and/or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. So that's a lot of things. And we're going to talk as we go through this more specifically about what that all means. Dissociative disorders are frequently found in the aftermath of a wide variety of psychologically traumatic experiences in children, adolescents, and adults. It's important to remember that dissociative disorders can be diagnosed at any age. Symptoms are experienced as unwanted intrusions into awareness and behavior with accompanying losses of continuity in subjective experience. What does that mean? Well, positive dissociative symptoms. Now, remember, positive and negative are like the positive negative in schizophrenia. Positive means the addition of something, negative means the subtraction of something. We're not saying that it's a good thing. That's not what positive means. But positive dissociative symptoms include division of identity. So, going from having one identity or one personality to two or more. Depersonalization and derealization. So maybe you're not going from having one personality to multiple, but you're going from being one entity to being one body and then sort of a fly on the wall. Negative dissociative symptoms such as inability to access information or amnesia or control mental functions that are normally readily amenable to access or control. You may freeze when this person switches into dissociative disorder. They may sort of unhook from their body. In dissociative amnesia, there's an inability to recall important autobiographical information, usually of a traumatic or stressful nature, that's not better explained by just ordinary forgetting. You may forget some things that happened when you were 5 or 6 years old, and that's not what we're talking about. We're talking about significant events or aspects of events that you probably wouldn't normally forget. Dissociative amnesia may be apparent to others. For example, the person does not recall something that others witness, or maybe the person can't recognize significant others. Now, we want to differentiate this dissociative amnesia from what we see as blackouts and substance use. So, there are a lot of times when people who heavily use substances will get to the point of intoxication where they black out, they don't remember what they did, and they wake up the next morning and people have to tell them. That's not dissociative amnesia, that's substance use. The dissociative amnesia is not attributed to a medical condition, a substance disorder, or other mental health issues, including PTSD. In PTSD, there's going to be some forgetting of particular events of the trauma. So we want to rule out or differentiate between PTSD, where the amnesia is specifically associated with a trauma and other aspects. Dissociative amnesia causes clinically significant distress or impairment and may or may not include dissociative fugue. In dissociative fugue, the person leaves their home or maybe goes to a different place in their home, but has no memory of the movement. They get from one place to another and they kind of snap out of it in that new place. They don't remember how they got there and they don't remember even wanting to go there. Again, we want to separate this from something that's a little bit more typical, maybe something that we call like highway hypnosis or autopilot, where you're driving, for example, to work and you don't even think about where you've got to turn. You don't think about what street you're on. You just sort of know this because you've done it a million times. So your brain sort of goes on autopilot. You get from your house to your office and you don't really remember the drive. That's because you were lost in your own thoughts. You weren't being mindful. You were just kind of completely checked out. You weren't in an amnesic state. You were dealing more with monkey mind. So we do want to separate the typical from the diagnostic issues. In depersonalization or derealization disorder, there's persistent or reoccurrent experiences of depersonalization or derealization. In depersonalization, there's a detachment or being outside of one's own thoughts, feelings, or actions. So the person may feel like a fly on the wall. They don't feel like they're part of their person anymore. They're somehow separated. In derealization, the person has a detachment from their surroundings. It may feel dreamlike, foggy, lifeless, or sort of visually distorted. Now, you may see some of these depersonalization and derealization symptoms, for example, after the use of a hallucinogenic type of drug. Not terribly uncommon. However, the depersonalization and derealization is attributed to that substance. When there's no history of substance use, especially hallucinogens, then obviously we need to look for other explanations. And during these experiences in depersonalization and derealization, reality testing remains intact. They recognize that the world is not actually foggy. They recognize that they're not actually outside of their body. It just feels that way. So, this would be the difference between your schizophrenia spectrum disorders when reality testing is not intact. It's not attributable to a medical condition, substance use, or other mental health issue, including PTSD, and it causes clinically significant distress. People with PTSD or with borderline personality, and although it's not an official DSM diagnosis, CPTSD often experience episodes of depersonalization and derealization, as well as they may experience some elements of dissociative amnesia. So, we do want to recognize that those symptoms exist and figure out if they have other criteria of borderline personality or do they have other criteria of PTSD, or are the symptoms confined to what is present in depersonalization or dissociative amnesia? So, dissociative amnesia and derealization are symptom specific disorder presentations. When we get to dissociative identity disorder in a minute, you're going to see elements of depersonalization, derealization, dissociative amnesia, plus some more. Likewise, in PTSD, borderline personality, and a lot of these other disorders, we're going to talk about in differential diagnosis. So there may be elements of dissociative amnesia and or depersonalization or derealization, and there are additional symptoms. So let's talk about the big one, dissociative identity disorder or DID. And I say the big one because there are a lot more symptoms in this, and this is the one that people talk about more often, whereas dissociative amnesia and depersonalization are often somewhat, more common. Dissociative identity disorder is the one that gets more attention in this group. So, for DID, this used to be called multiple personality disorder way back in DSM 3 or maybe even in the DSM 4. I don't remember when it changed, but now it's called dissociative identity disorder. The individual has two or more distinct personality states observed by others or by the individual. The other people don't necessarily have to perceive it. So the individual may experience it. They experience themselves as a 30 something year old adult, but they also at times might experience themselves as a 5-year-old child. They feel like they're that 5-year-old child. So they're actually switching. It's not like they want to act like a 5-year-old. They feel like they are a 5-year-old. So they have two distinct personalities at least, and they have done brain scans on people with dissociative identity disorder. And with each personality, different aspects of the brain light up, and the brain lights up in different ways. So there's definitely some neurological differentiation between the different alters. And alters is the word that we usually use to refer to those alternate personalities. So the individual has two or more distinct personality states observed by others or experienced by that individual, characterized by alternations in the sense of self and personal agency, what they have control of. When they switch to an alter, a lot of times the host, for example, may not feel like they've got control where they can pull back and become themselves again. They can't just switch back to being the host. They lose a sense of personal control when that other alter takes over. Affect behavior, memory perception, cognition, and or sensory motor functioning may also change. So in people with two alters or two different personalities, a host and an alter, which is obviously the simplest form, they may write very neatly, they may be very organized, they may be very professional in their host personality. When they're in their alter, they may have sloppier writing, they may be more argumentative and aggressive, they may be more reactive, they may act and perceive the world very, very differently. And interestingly enough, there's been a theory proposed that each personality, each alter, develops its own schema because they experience, remember, and encode the world through their eyes. So the 4-year-old alter is going to have a very different schema and is going to react very differently to the world than the 34-year-old alter. So that's kind of interesting. So whenever those alters are engaged, that means that they're forming new schemas that they may or may not be beneficial to the recovery process. And I have a supervisee right now that's working with somebody with DID, and we'll talk about prevalence in a bit, but this is very rare. And the first time I've encountered a client in my 12 years in the field. Depersonalization and derealization will be more common, DID is rare, and the movies just really seem to love this one. I'm not sure if I've ever actually seen it portrayed accurately or well. I think that there's some argument that the main character in Fight Club could have DID, or that Scorsese movie, Shutter Island, or if you've seen Split, the M. Night Shyamalan film, there's a murderer with 24 personalities. And I think the take home here is that DID gets a bad rap. These characters are bad guys, murdering, unethical. And the reality is that most people with DID are just very harmless. And 24 personalities, 24 alters is, it's Hollywood. It's not an accurate portrayal of what's commonly seen here. My supervisee's client has the host personality and one alter, maybe two. They're working on figuring it out. They're also super interesting as one of the alters has some gender dysphoria, like what we talked about last week, and they like to use they, them pronouns, whereas the host uses she, her pronouns. The individual has two or more distinct personality states. Individuals may report that they have a feeling that they suddenly become depersonalized observers of themselves and feel powerless to stop. They may have perceptions of voices. We're going to talk about that in a little while, on and off, about differentiating dissociative identity disorder from schizophrenia spectrum disorders. The perception of voices could be a child's voice. They might hear a child's voice talking to them, persecutory voices, or command hallucinations. So these are common. And remember, I said that you have to have the symptoms and all the other symptoms for schizophrenia. In schizophrenia, you typically don't have the two personalities. In dissociative identity disorder, you don't have a lot of the other characteristics of schizophrenia. So when you sit down and look at all of them on paper, you can more clearly differentiate. In some cases, the person reports multiple independent thought streams over what they feel they have no control. So think about going to a cocktail party or a luncheon or wherever you go, and you're in the middle of a conversation and there are multiple people talking and you have no control over what they say. You're almost invisible to them. And that's what it might be like to some people. That's the one that's been described to me. They may also have hallucinations in all sensory modalities. They may have strong emotions, impulses, thoughts, and even speech or other actions that suddenly materialize without a sense of personal ownership or control. The person suddenly starts acting a certain way and they're not sure why they're acting that way. They feel like they're being driven by a remote somewhere. Conversely, thoughts and emotions may unexpectedly vanish, and speech and actions are abruptly inhibited. So, if their alter is very talkative and maybe extroverted, and then they switch back to the host or they switch to a different alter, they may find that they become abruptly inhibited. They go from being that sociable personality to one that is not so much. Attitudes, outlooks, and personal preferences, including food activities and their perception of gender identity, like my supervisee's client. You may not have all female alters in somebody who's biologically female. They may also report that their bodies feel different. They suddenly feel like a small child or of a different gender or different ages simultaneously. They feel like a kid and an adult, or even an adult and an older person at the same time. Dissociative fugues with amnesia for travel are also common in people with dissociative identity disorder, where they will enter into this dissociative state. So maybe an alter will take over, they go somewhere, or maybe even maybe it's the small child alter that could have been abused. They hide under the bed, and the host might come back to hiding under the bed and not know how they got there or why they got there. Individuals may report suddenly finding themselves in another city, at work, or even at home in the closet under the bed or running around the house. Those things are important to explore if the person remembers when they came to, what they were doing. A lot of times, not always, but a lot of times, that might give you some clues as to traumas that may still need to be processed. In criterion B for dissociative identity disorder, the person has frequent gaps in recall of daily, either ordinary or traumatic events. They may not remember going to work that day, or if there's a traumatic event, they may not remember aspects of the event or the event itself. They may not remember important personal information, and this is also inconsistent with ordinary forgetting. It's not something that they just can't recall. So most of us don't know our driver's license number, for example. So you wouldn't expect somebody to be able to recall that, but you would expect somebody to be able to recall their birthday. Gaps in any aspect of autobiographical memory may be present. So this person may not remember important life events, their birthday, the birth of their child, their wedding, or they may lack recall of all school experiences before high school. They try to remember junior high or elementary school or any of those times, and it's just blank. There's nothing there. They may experience lapses in memory or recent events or well learned tasks or skills. This is something that's really important to take a look at. A lot of times, there are memory problems in people with dissociative identity disorder, both recent memory and long term memory. There may be gaps, especially around that traumatic time, but there may also be gaps in the present that represent when one or more of the alters took over. And well-learned skills could be example, maybe one of the alters may know how to type and another one may not know how. Maybe one knows how to play the piano and another one may not. It's almost like the brain has become compartmentalized and certain compartments are only accessible by certain alters. And there may be a discovery of possessions that the person has no recollection of ever owning. They may go into their jewelry box and they've got a necklace there that they don't remember getting. They'll go into their closet and there's clothes that they don't remember buying. We again also need to differentiate this and make sure that there's no other explanation for it. Excessive shopping during a manic episode could result in some lack of recall on possessions. There's ordinary forgetting with early onset dementia and with Alzheimer's disease. The majority of time, remote memory stays intact. Recent memory becomes more difficult. People have more confusion in what's going on. Asking them what they did today is more problematic than tell me what happened when you were in high school 50 years ago, or even, for early onset 20 years ago. So there's that big difference between early onset dementia or Alzheimer's and dissociative identity disorder. These experiences are frequently reported as ego dystonic and puzzling. Now, one of the things that I found puzzling was in the DSM 5 TR, they seem to contradict themselves. The criterion B very clearly says that they're ego dystonic. So the person recognizes that something is not quite right, it doesn't make sense what's going on. Or even when they experience the depersonalization, they recognize that their reality testing is intact. So they recognize that it's not typical to feel like they're a fly on the wall. So that's ego dystonic. They're not sure why they're experiencing it. However, in another place in the DSM 5 TR, in associated features, it says individuals with dissociative identity disorder often conceal or are not fully aware of disruptions in consciousness, amnesia, or other dissociative symptoms. It's hard for them to be ego dystonic and puzzling for the person to not be aware of them at the same time. So I was a little confused by that, but I figured I would just put that out there. Minimization or rationalization of amnesia is really common if somebody finds something in their possession that they don't remember getting. They can often make a rationalization for how it got there or why. Like, oh, somebody must have just given it to me. I just put it aside and forgot about it. The symptoms in criteria A and B cause clinically significant distress or impairment in one or more areas of the following. If it didn't, they probably wouldn't be in your office. So they're presenting, that's likely that it's causing them problems. So the experience is not a normal part of broadly accepted cultural or religious practice. In children, symptoms are not better explained by imaginary playmates or other fantasy play. In the possession form of dissociative identity disorder, there was a caveat in the DSM 5 TR for cultural explanations, and in certain cultures, there may be times in which the person is possessed, for example, by a spirit or an entity. However, it doesn't cause clinically significant impairment or distress and is culturally recognized and embraced in whatever format they're in. For example, speaking in tongues or in seances, or when somebody from the beyond or in spirit is speaking through a medium. So, like in Ghost, Whoopi Goldberg is not experiencing DID. She's just got Patrick Swayze speaking through her. And there are probably so many better examples of that that I could have picked. But anyway, that would be considered culturally sanctioned. It's not something that happens just kind of willy nilly. The symptoms are not attributed to the effects of a substance or another medical condition. Additionally, symptoms worsen during times of internal or external stress. So, internal stress could be pain, it could be illness, it could be a variety of different substances, especially with disinhibitors like alcohol. That make it harder to suppress some of the memories, which increase internal stress. Or external stress, such as being too tired or having a lot of environmental demands that are impairing them. Most individuals with non possession DID do not overtly display or subtly display their discontinuity of identity. So, people with DID are not going to be like what you would think of, like how Hollywood portrays them. It's going to be relatively subtle. You're not going to have somebody who's talking to you and drinking coffee one moment and then all of a sudden has regressed to a 4-year old alter just spontaneously. That rarely happens. Now, it could happen, yes, but it rarely happens. And the person has often developed some sort of compensatory strategies to kind of be able to keep things under control. In a lot of cases, they're distressed by their discontinuity of identity. They recognize that this doesn't happen to other people that they know. Many people with DID have dissociative flashbacks and subsequent amnesia for the content of the flashback. So they may have a flashback to something that their alter did, and then when they come out of the flashback, when they get regrounded, they won't remember. They know that they had a flashback, but they can't really remember the content of it. For differential diagnoses, you want to differentially diagnose DID from dissociative amnesia. And in dissociative amnesia, the person maintains a continuity of personality. And that's going to be the predominant feature in the differences of dissociative identity disorder from pretty much everything else. In depersonalization and derealization, the person does not experience the presence of different personality states, nor do they typically report dissociative amnesia. So you've got depersonalization and dissociative amnesia, but only one personality, then you may have somebody who has both of those or PTSD. I would probably look into that too, but they're not going to have DID unless they have at least two distinct personalities. In bipolar disorder, the relatively rapid shifts in behavioral state in individuals with DID, usually within minutes or hours, are atypical even for the most rapid cycling individuals with bipolar disorder. That's something that you really pay attention to. There's a lot of misdiagnosis of people with bipolar 2 who actually have dissociative identity disorder from what the research says. So we want to pay attention to this rapid cycling. If somebody is going in several hours or even a couple days between depressed and hypomanic, we want to take a look at that because it's really, really, really fast, even for cyclothymia or bipolar 2. And fictitious disorder and malingering. The person is relatively undisturbed by or may even seem to enjoy having the disorder and become angered if you try to rule out the diagnosis of dissociative identity. So, one of the things that you want to ask yourself if they're presenting in your office with dissociative identity is there a material gain to it? Are they trying to excuse themselves from a violent outburst? Are they trying to excuse themselves from theft or from something else that they did? So the first question is to try to differentiate a little bit. Now, it's possible somebody with dissociative identity may have a bad actor in their alters, but we do want to consider most of the time that's not the case. We want to consider, is there a gain that this person hopes to achieve by having this diagnosis? Remember, I said most people with dissociative identity disorder recognize that this is not typical of most other people and therefore are greatly distressed by it. And they don't want to have the disorder. They'd be thrilled if you could just say, no, 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 it's this other thing over here and it's this easy peasy treatment. It's not that. So, a person who's malingering or has fictitious disorder may ask clinicians to find traumatic memories. Most people with dissociative identity disorder do not want to remember. The DID developed as a way to block out those memories to help survive and to help to cope. They don't want to go there. So, somebody who's curious and really wants the therapist to dive in, again, may have an ulterior motive. People who have fictitious disorder create limited stereotyped identities, and feigned amnesia is often related only to the events for which the gain is sought. So, the only time that they happen to have amnesia is when engaged in this violent episode or when they did this other thing. And sometimes it'll be generalized a little bit, like they may talk about having a dissociative fugue where they'll end up going from one place to another. They totally don't remember getting there. They don't remember doing whatever they did during that period of time, and we'll just say it's frequent. But the other episodes of amnesia are related to or additional instances of that one that they're trying to excuse or mitigate. Increased knowledge evidently impacts dissociative identity disorder presentation. Now, this isn't from the DSM 5 TR, this is from an article I read that if they don't have DID, if they have fictitious disorder, they're more likely to start to learn about DID. They're going to embrace it the more symptomatic they're likely to become. And for the person who's malingering, fragmented personality is often an important topic of discussion. They want to talk about all of their alters. They want to know what's going on and they're going to be curious about it. People who have DID often don't want to. They don't want to acknowledge it. It's just too painful, too stressful to think about. In terms of PTSD, depersonalization and derealization symptoms in dissociative identity disorder may occur not only in response to PTSD reminders, but also in an ongoing fashion in daily life, including in response to stressful situations. So, in PTSD, a lot of times the depersonalization or derealization happens in response to a trauma trigger. Totally get that. In dissociative identity disorder, the degree of emotional dysregulation is so intense that any stressor of a certain level, depending on the person, will often trigger the emergence of the alters, the emergence of depersonalization or derealization. So we want to identify when the depersonalization or derealization is happening. Is it in response to the trauma triggers? Now, you might be able to argue that ongoing traumatic events in someone's childhood may have coded pretty much everything to be a trauma trigger. So, especially if you're talking about CPTSD, then we may need to be a little bit more cognizant of that. Borderline obsessive compulsive personality disorder, antisocial personality disorder, and narcissistic personality disorders have a lot of features in common with dissociative identity disorder, but personality disorders, according to the DSM, are more stable and pervasive. Whereas the person with DID switches personalities, the person with borderline might have unstable sense of self. They may alternate from valuation to devaluation, but it is relatively cohesive package and there's not much deep non-trauma related depersonalization or derealization. It was interesting in one article I found that said up to 70% of dissociative identity disorder patients are initially diagnosed with borderline personality disorder. An interesting fact in terms of schizophrenia spectrum disorders, the symptoms in schizophrenia are egosyntonic. So if a person is having hallucinations in schizophrenia, if the way that they're experiencing the world makes sense to them, that they don't understand why you don't see it the same way that they do. Whereas in dissociative identity disorder, the reality testing is intact. They recognize that what they're experiencing is not reality how it is. And in schizophrenia spectrum disorders, there's often not that dissociative amnesia. Now, I added hallucinogen persisting perception disorder, where people who've taken hallucinogens, particularly LSD, may have sporadic hallucinations years after the substance dose. However, there's no splitting of personality, there's no amnesia. So you would differentiate hallucinogen persisting perception disorder from depersonalization disorder or dissociative amnesia, but more the depersonalization and derealization disorder. In addiction, we want to examine that the symptoms are not caused by a blackout. Are the symptoms of the two distinct personalities caused by, or do they occur when a person is using a particular type of substance? And when they're using a different type of substance, or when they're detoxing or in withdrawal. Remember, the dissociative identity disorder or personality switch pretty rapidly, but in addiction, there's definite triggers, there's definite precursors to the presentation. And in dementia and delirium, people start having more difficulty processing information, understanding what's being said, and their near memory and their ability to learn new things is compromised. But a lot of times, their historical memory, if you go back, a few years, that's not as compromised as much. So, if there's this rapid onset of cognitive symptoms, it's really important to get them evaluated by a physician to make sure that they're not experiencing Wernicke-Korsakoff syndrome or early Alzheimer's or dementia. We certainly want to rule out any of those organic causes. In terms of comorbidity, anxiety is very common in people with dissociative disorders, not just dissociative identity disorder, but all dissociative disorders in general. And that makes sense if their condition, whichever one we're talking about, if the condition developed as a result, most commonly to trauma, then that means that they were stripped of their sense of feeling safe and stripped of a sense of personal empowerment. And they're going to continue to be anxious until they can feel safe and empowered again. Addiction is not uncommon because people are trying to quell, silence, suppress the distress that's caused by the fragmented personalities or the dissociative experiences, and or they may try to self-medicate to cope with the memories of the trauma. Depression, remember, depression mainly is key features of a sense of hopelessness, helplessness, low motivation. And people who are experiencing these switches or depersonalization may feel depressed and they may feel exhausted. That's not uncommon. PTSD is, of course, very often comorbid because the cause or trigger for the development of the dissociative disorders is often trauma itself. So we can diagnose PTSD and one or more of the dissociative disorders together. Self injury, unfortunately, is also very common in people with dissociative disorders. For some people, they use it as a tool to try to help them stay grounded and not dissociate. For others, it's a coping mechanism to deal with the distress that's caused by the dissociation. But it's very, very common and very, very problematic. It needs to be a focus of clinical attention. Brief psychotic symptoms are not uncommon, hallucinations and delusions. It's important to help the person recognize them for what they are and develop tools to deal with them. Atypical antipsychotics have been found to be helpful for people who are having a lot or frequent psychotic symptoms, and that can help. However, atypical antipsychotics also tend to be very sedating. So, not everybody wants to take them all the time. It may be one of those things that people take when they're having an exacerbation. Interestingly, of all the personality disorders, avoidant personality disorder is most commonly co occurring with dissociative disorders. It makes sense, though. I mean, you would think it might be borderline or antisocial, but avoidant makes sense because if the person has been exposed to severe trauma, then they might not trust other people. They might not trust the world. They might not have the energy or desire to engage with other people. It's just they're sort of over it. Eating disorders and obsessive compulsive disorder are also common co occurring issues in dissociative identity disorder. And you can hypothesize for quite a while about why that might be. But in each individual presentation, and I emphasize this a lot in each individual presentation, it's important to look at that person as an individual, look at that person's symptoms, and say, what are these symptoms communicating? Behavior is communication. What are these symptoms communication? What function are these symptoms serving for this person at this point in time? Prevalence. Now, prevalence very interesting. In the US, prevalence is for dissociative identity disorder is identified to be 1.5%, so 3 out of every 200 people. And for some reason, the DSM-5-TR also highlighted that women in Turkey, the prevalence is 1.1. Not exactly sure why they just plucked that out of the thin air. However, I mentioned that before, more than 70% of people with dissociative identity disorder are initially diagnosed with borderline personality disorder. Now, that doesn't even include all the people that are misdiagnosed with borderline, with bipolar 2. So, if we take into account the underreporting, the prevalence of dissociative identity might be as high as 2.6%. I saw some stuff saying maybe 5%, which, that seems like a lot. Suicide, another interesting but disturbing, disheartening fact is over 70% of patients with dissociative identity disorder have attempted suicide. Not just had an ideation, but they've attempted it. If you're working with somebody who's diagnosed with DID, who has dissociative symptoms, who has trauma, who has borderline or bipolar 2, especially if you haven't ruled out that it is a dissociative identity disorder, it's important to be extremely aware of how frequent and common suicide attempts are in this particular population. Multiple attempts are common, and other self injurious and high risk behaviors are also prevalent. And I think next semester you're taking testing and appraisal. So, setting you up for that in terms of diagnosis, the Dissociative Experiences Scale, the DES, the Structured Clinical Interview for Dissociative Disorders Revised, or the SCID-DR, or Dissociative Disorders Interview Schedule are some of the most common diagnostic tools to use here. Dissociative identity often represents a survival strategy developed to cope with overwhelming stress or trauma. The defining feature of DID is the presence of two or more distinct personalities, potentially more common as currently diagnosed. And we didn't talk about it, but treatment involves trauma processing with the host and the alters in a safe and supportive environment. Give me an email, reach out to me if you have any questions. I'd love to talk about this one. Thanks.